Okay, so we're going to go ahead and get started. We're live here on Zoom, but also live on Facebook. So first of all, hello everyone, and thank you all for joining another Outcomes for Me webinar in the Ask the Expert series. Today, I am delighted to welcome board certified plastic surgeon, Dr. David Light from New York Breast Reconstruction and Aesthetic Plastic Surgery. Dr. Light is a fellowship trained board certified plastic surgeon with a dual practice focused on breast cancer and aesthetic surgery. Dr. Light's expertise includes microsurgical breast reconstruction techniques, including deep flaps, surgical treatment of lymphedema, and sensory restoration of the reconstructed breast. He has a special interest in helping those who were either not offered reconstruction or are unsatisfied with their current reconstruction. Dr. Light has authored numerous peer-reviewed articles and lectured on breast reconstruction nationally. He recently helped us as a contributor to the newly launched Breast Cancer Resource Center in the Outcomes for Me app. I'm also delighted to share today that Dr. Light is offering free consultations for members who have downloaded the Outcomes for Me app. To schedule your consultation, log into the app tomorrow and look for today's webinar on the homepage with the link in it to book your free consultation. Today, Dr. Light is joining us to talk about everything patients need to know about breast reconstruction as it pertains to breast cancer. And for those that don't know me, my name is Maya Saeed. I'm the co-founder and CEO of Outcomes for Me. Outcomes for Me wants to help and empower breast cancer patients with the tools and resources to better navigate their care. Through our mobile app, patients can have access to free resources and information, including clinical trials to help them manage their disease. The format of today's discussion will be one-part discussion and one-part Q&A. We have gotten a few questions from our users prior to this webinar, but we encourage you to send us questions via Zoom or Facebook Live, and we'll do our best to get them answered during our time together. And I see actually we're already starting to get questions here on the Zoom, so that's great. So let's kick things off and start them off by allowing you, Dr. Light, thank you so much for being here, to give a brief introduction about yourself, and we will jump then right into the questions and answers.
No, thank you for that very kind and warm introduction. So I think you covered me, Maya. There's not much more I can add about myself. I will share with you that New York Breast Reconstruction and Aesthetic Plastic Surgeon, where I'm a member of a 5-person group. We all specialize in breast reconstruction. We do about 500 autologous or natural tissue reconstructions a year, and an even greater number of implant reconstruction. So breast reconstruction is a focus of our practice. It's something that we all love, enjoy, and has really become a part of our lives. And so it's something that I love, and I'm happy to be here and look forward to tonight's webinar.
Great, so let's get started. So just to get going, I want to have a number of questions so everyone joining us today is on the same page. So when should a patient consider breast reconstruction in the context of a breast cancer diagnosis?
So really as early as possible. The usual sequence of events is, someone will either possibly feel a lump in their breast, or they'll go for their routine imaging and something's discovered. After a biopsy has, proven a diagnosis of breast cancer, the patient usually meets a breast surgeon who then will decide if either surgery is the next best option, or if they would benefit from either chemotherapy or hormonal therapy first. So as all of that is happening, that's the best time to meet a plastic surgeon, a board certified plastic surgeon who's got experience in breast reconstruction, so that they can start to discuss with you all of the options. And even if you're going to go on to have chemotherapy or hormonal therapy first, and surgery may not be for a number of months, it's still helpful to have that consultation early, because there's a lot of moving parts. The procedure has to be scheduled at the hospital. There's a breast surgeon involved. There's a plastic surgeon involved. And so having a little bit of lead time is critical. And for many patients coming off of chemotherapy or hormonal therapy, there's actually a window once they finish that therapy that they need to have their breast surgery. And so getting all your ducks in order as early as possible is definitely helpful.
Okay, no, that's very helpful to know. And just, so what type of breast reconstruction is right for breast cancer patients? And also, can you go through some of the risks and benefits of each type of breast reconstruction?
Sure. So, everyone is going to be a little bit different. And so the best reconstruction for, patient A is going to be different than patient B. And so the way you figure out what's your best options is through a consultation, because during the consultation, the plastic surgeon is going to assess, what your general health is. Do you have any comorbidities? Are you a smoker? Are you a diabetic? Do you have high blood pressure? And then they're going to do a physical exam. And the physical exam allows them to assess a number of things: your breast size, where the nipple position is. Are you a good candidate for a skin-sparing mastectomy or a nipple-sparing mastectomy? And then they're going to examine, your entire body, the abdomen, the thighs, the buttocks, the back, and they're going to look for possible areas where a natural tissue reconstruction or an autologous flap could be performed. And so at the beginning of the consultation, you may have 30 or 40 reconstructions on the table. By the end of the consultation, after all of this is assessed, the plastic surgeon can then narrow down the options that are best for you. And that's when you can kind of get into the nitty gritty. And that's, at this point in the consultation, you should be reviewing before and after photos. So you have an idea of what things are going to look like afterwards, so that expectations are set properly. And then you want to talk about risks and benefits, which gets to your second question. So generally speaking, for post-mastectomy reconstruction is done either with an implant or with your own tissue. And so each one of those categories have general risks and benefits. The advantage of an implant reconstruction is that it's basically a faster surgery. The recovery time is shorter, the surgery is shorter, and so that's certainly an advantage. The disadvantage is that there's a little bit more maintenance with implants. They may not be a permanent device, so you may need to have an implant exchange down the road. If you have a silicone implant placed, the FDA recommends that there's imaging done on that implant roughly every 2 years. You can wait 3 years after it's placed, and then every 2 years after that. The other things that we're concerned about with implants is infection and capsular contracture. So the infection rate is low, but because it's a foreign material, oftentimes when implants do get infected, the only way to clear that infection is to remove the implant. The other thing that I mentioned was capsular contracture, which refers to excess scar tissue that can develop around an implant. So those are the pluses and minuses of implant reconstruction. Natural tissue reconstructions are great because the appearance is often softer and more natural than an implant. There's certainly longevity on your side. Once a natural tissue reconstruction is healed, there's no exchanging it down the road. So it's going to be with you for a lifetime. Disadvantage is that it's a little bit of a longer surgery up front, and the recovery, it's not tremendously longer, but it may be another hour or two in an operating room, and it may be an extra week or two of recovery.
Great. I do actually, relative to this answer, we just got on the Zoom a question that's connected to this from Regina. The question is, I had my implant surgery a little over 10 years ago. Recently from a CT, it was discovered that one of them has ruptured. Can I put this surgery off until COVID isn't a great threat?
So hard to know when COVID is going to end and when it's safe, and it all kind of depends on where Regina is located. There are certainly states that are higher right now, and that would certainly be of more concern. Where Maya and I are in the Northeast, the numbers are relatively low, and I would encourage you to just go ahead and take care of it. When an implant ruptures, there's two types of rupture. There's an intracapsular rupture. So that capsule that I had mentioned before that can tighten with a capsular contracture, that's around every implant. So an intracapsular rupture means the implant has ruptured within this capsule of scar tissue. An extracapsular rupture means that the implant material, usually silicone, has now made it outside of the capsule. And so it's definitely ideal to exchange and remove a ruptured implant and do the exchange while it's still an intracapsular rupture. So there's no emergency. It doesn't have to be done next week or the week after, but sooner rather than later.
Great, thank you. What are options for women who are unhappy with their previous breast reconstruction surgery?
Well, the good news is there's almost always options, and it really depends on what's bothering you about your previous reconstruction. So I'll give you a few examples. Sometimes with a implant reconstruction, it's just the implants over time have settled a little bit. The position may not be as perfect as it was immediately after surgery, or your body has changed a little bit with time, and now you either want a smaller implant or a larger implant. So that may be as simple as just adjusting the implant position, doing an implant exchange to the size that would get you to the place that you want to be. Other times there were complications with the reconstruction. There may be a little bit of scarring in the tissue. The patient may have developed a capsular contracture, had some issues with an implant. And then oftentimes in those situations, we're looking to exchange the implant for a natural tissue reconstruction.
Great. So let's talk now about more, kind of treatments, breast cancer treatments and their impact on timing or ability to have breast reconstruction. So in particular, starting with chemo-hormone therapy, does that treatment impact, people's ability to get a breast reconstruction and potentially the type of breast reconstruction they can get?
So it doesn't impact the ability to get the breast reconstruction or the type. Radiation can play a little bit of a role there because radiation can increase the chances of capsular contracture significantly, 2 to 3-fold. And so oftentimes if a patient has had radiation, we'll educate them on that, and we may decide not to use an implant for their reconstruction. But chemotherapy and hormonal therapy, all options are still open. It can affect the timing though. So, if you're undergoing a staged reconstruction, for example, like a tissue expander reconstruction, so you had a mastectomy, the tissue expander was placed, or if you had a mastectomy and a deep flap was done, but you're planning on undergoing a nipple reconstruction, if it's determined that you need chemotherapy after surgery, everything is kind of put on a pause there. You undergo the necessary treatments, and then reconstruction resumes once everything is completed. Hormonal therapy is a little bit different. We can actually, depending on the hormonal therapy, still operate while the patient is undergoing hormonal therapy, because oftentimes it extends for months after chemotherapy has been completed. So hormonal therapy is a little bit more flexible.
And you did mention that radiation kind of limits a bit the options, right? So, anything to elaborate on that one beyond what you just said?
Yeah, so this comes down to, I've certainly done breast, and most plastic surgeons have done breast reconstruction on using an implant on someone that's had radiation. But this is where, informing the patient and, shared decision-making comes in. So we'll always educate the patient that, the risks are higher. But for some patients, that's kind of the way that they want to go. They understand that the risk of capsular contracture is higher. The risk of wound healing complications is higher with following radiation, especially with an implant. And so we all go into it with open eyes, and if there's any issues, they're dealt with on the back end.
And perhaps linked to that, or more broadly, can you tell us more about where research is going in this area? In other words, what is happening in terms of breast reconstruction field? Where's the research? What the future looks like? Sure.
So I think the breast reconstruction now compared to even 10 years ago has certainly evolved. The implants have improved. The biologic mesh that we're using as part of implant reconstruction has improved. The techniques for autologous reconstruction have certainly been refined. And there's more people performing the more refined techniques than there were 10 years ago. So, which is great for patients, because if there's more people performing these surgeries, it's a little easier to find them and to, you know, have all of the options available to you. I would say that some hot topics in breast reconstruction right now, one of them is sensory restoration of the breast. So especially with natural tissue flaps, trying to restore the sensory nerves, which are basically cut during a mastectomy, and repairing them with nerve grafts to the tissue flap that's moved up, so that the tissue flap has a little bit more sensation afterwards. It's never normal sensation of a breast, but any improvement is certainly beneficial. So sensory restoration is certainly a hot topic. There's a lot of research now also on quality of life issues after breast reconstruction, comparing different techniques, different modalities, and using validated surveys to assess patient, you know, work function, their sexual well-being, their psychosocial well-being, their physical well-being before and after surgery, to see what the effect of breast reconstruction is on them and whether one technique is a little bit better than another technique.
Is there, actually, this is really interesting, is there any early data on the quality of life, or that's just still, you know, kind of data being collected?
Breast reconstruction definitely improves quality of life, both immediate breast reconstruction and delayed breast reconstruction. Although immediate reconstruction in many studies has an advantage because a patient has the reconstruction immediately after surgery, and there's certainly some benefit to that.
Okay, great. So we're going to go now to the direct questions we've been receiving, both before from our users before the webinar, but also live. So, you know, I'm seeing questions coming in. Please feel free to ask questions either on the Zoom or Facebook Live. We'll go to as many as we can. So let's start with this question that we got actually from one of the people using our app. And I'm going to read the question as received. I'm still undergoing chemo for TNBC in breast and lymph, and do not have a genetic predisposition to breast cancer. I was told a mastectomy would not be necessary. If the decision is up to me, how do I determine if a double mastectomy is the right choice? And I assume in this case, we're talking, you know, perhaps, and now I'm extrapolating on the question, is in the double mastectomy in the context of then a full breast reconstruction, as opposed to kind of, you know, something different.
Yeah, so I think with the patient has a breast cancer on one side, she's undergoing treatment. And so what she's questioning is, what do I do with the other breast? Do I just have treatment on my one breast that's affected and leave the other breast alone? Or do I just say, you know what, I'm more comfortable with a double mastectomy and I'm going to treat both? And that's really a very personal decision. The data shows that it's safe to continue to monitor the other breast, that the chances of developing a breast cancer in the other breast is not significant. But for many women, it's a peace of mind decision and a quality of life decision. So they may have had multiple biopsies previously. They may have had previous scares with the breast cancer where there was or previous breast cancer in the breast, and now this is a second round. So whatever the stressors are, and sometimes you don't need a previous stressor. Sometimes it's just the fear of going through the whole process again. And what some patients will describe to me is they feel like they're living from mammogram to mammogram, ultrasound to ultrasound. And so on one side, you have data that says it's safe for you to monitor and that you don't have to do a mastectomy on the other side. But it's hard to put yourself in that patient's shoes and live, you know, day to day. And so many women who feel this way opt to do a bilateral mastectomy because it gives them peace of mind. Now with that, they have to understand that the complication rate is, it's not doubled, but a mastectomy just on the right breast and a mastectomy on the left breast, it's almost two separate operations that just happen on the same day. So it is possible that everything goes well with one breast, but then you may have issues on the other breast. And so, you know, again, if I think a patient is counseled well and understands all of the pluses and minuses, then they should be able to allow to make that decision for themselves.
Thank you. Another question from Patricia. So actually, she's had the double mastectomy at the VA, and I'm waiting to have the reconstruction. I'm interested in using my own tissue instead of an implant. Is that possible?
So hard to tell without an examination, but for most patients, it's possible. You know, I would say the most popular place by and far to do a natural tissue reconstruction is the abdomen. It's the lower abdomen, and it's usually a deep flap. The second most common place to take tissue from for reconstruction is the inside of the thighs, but there's a multitude of other locations: the outside of the thighs, the saddlebag area, the lower back. And so, you know, usually there's an option for a patient who, you know, really feels like that's the best way for her to go. The only way to know what the best option is unfortunately an examination.
Actually, related, similar question that we also got here. I had a radiation in previous breast cancer treatments. Now I have tissue expanders after double mastectomy. I plan to get implants, but can I still consider natural tissue reconstruction?
Absolutely. Yeah. So there are many times where someone will start with the tissue expander and then decide, you know what, I'm not comfortable. I don't want to continue this. I'd rather change course and move forward with the natural tissue reconstruction. And you most certainly can do that. The tissue expander comes out in the same exact fashion, and instead of replacing with an implant, you replace it with your own tissue. And in some cases, for example, for patients where we know they're going to have radiation afterwards, there is a technique called the delayed immediate reconstruction. The team at MD Anderson popularized it and wrote about it, introduced it. And essentially, you start at the time of the mastectomy. The immediate part of the reconstruction is placement of a tissue expander. You then undergo all of your treatments, chemotherapy and radiation therapy. The tissue expander is radiated. And then after you heal from radiation therapy, you go on to have the tissue expander removed and a natural tissue flap placed.
Great, thank you. Another question we've received, I had the breast reconstruction flap surgery in 2017. I now have a hernia and a huge bulging abdomen. My plastic surgeon has been unable to explain the bulge. No fluid has been detected. It is extremely uncomfortable and unsightly. I must wear a compression garment to help increase the bulge and the pain. Please help. So anything that, you know, from a essentially aesthetic surgery, reconstruction that, you know, could help this person.
So usually in that situation, the reason for the bulge, and this can happen with, it's most common with the tram flap. So with the difference between a tram flap and a deep flap or DIEP flap is that a tram flap removes the skin and fat from the lower abdomen up to the breast by keeping it attached to the muscle. So this means that the muscle has to be cut, and that therefore weakens the abdomen. When you weaken the abdomen, it can lead to a bulge in the abdomen. So this is a very common issue with tram flaps, but it can happen with deep flaps as well. And so not all deep flaps are performed at the same level and with the same precision. When you're in consultation and you're interested with a deep flap, one of the things to ask the surgeon is, you know, what is their bulge rate? How often do they see it, and how do they prevent it? And the way that you prevent it is you need to maintain the nerves that innervate the six-pack muscle or the rectus muscle. Because even though you may preserve the muscle with a deep flap, if you've injured the nerves, then that muscle becomes weak and basically flaccid, and it's almost as if it's not there functionally. And so you can develop a bulge in that sense as well. One of my partners, Ron Israeli, actually, Dr. Israeli, wrote a paper on treatment of tram bulges, and he sees patients for this reason, and actually our entire practice does nationwide. And so it's not a uncommon thing. It can be treated. but best thing to do is to avoid it by, trying to avoid tram flaps. And then if you have a deep flap, really paying attention to those nerves so that the muscle remains functional.
Okay, great. A question that just came from Judith, and actually in a similar potential theme, regarding infected hematoma and incision site, followed by weeks of wound therapy clinic treatment with packing, finally healed but left a significant divot in the underarm area. This was 3 years ago. Can reconstructive surgery take place this long after?
Yes. Yeah. So this is what's called secondary wound healing. So you had
say it again, doctor. I didn't hear you. You broke there. Yeah.
So primary wound healing is when you bring the skin edges together and it heals beautifully. Secondary wound healing is when there was an issue, whether it's infection or bleeding, an open wound develops and then you allow it to heal secondarily. And so the scar with secondary wound healing is always more significant, and scars naturally contract, and that can lead to a contour abnormality, a divot, an indentation, however you want to call it. So that in many cases can be repaired. There's no time limit. In fact, waiting actually will cause the scar to soften, and it actually makes the surgery a little bit easier and more successful. So what's commonly done is either the scar is removed and the tissue is brought together, sometimes fat grafting, which is performing liposuction and then transferring that fat by injecting it into the area, can fill these indentations and improve the contour.
Okay. And Betty actually, it's kind of asking the question around, she had her mastectomy in 2009, so it's been a while. Am I still able to get reconstructive surgery? And then PS Canadian, so in Canada.
So I don't know what the laws are in Canada and if there's any expiration. I know the healthcare system in Canada is excellent. If I had to guess, I would say no, that you're still a candidate. In the US, there is the Women's Cancer Right Act of 1998, which basically enforced the fact that breast reconstruction is reconstruction. It's not a cosmetic procedure. If you go back to the early 90s and 1980s, many insurance companies did not cover breast reconstruction. So the act in 1998 really, changed things, and there's a few specific points to it. One is that all stages of breast reconstruction are covered at any time, so there's no expiration. The other thing that it covers is for patients who want to have a reconstruction on one side that may leave an asymmetry compared to the other breast. And so procedures for symmetry purposes on the other breast are covered. That can include placement of an implant, a breast lift, a breast reduction, whatever the plastic surgeon needs to do to match the unaffected breast to the reconstructed breast.
And how about, actually, just curious, so since it's been so long, does it impact at all the result in any way or the approach?
It actually does a little bit. So the advantage, and this is actually the difference between an immediate breast reconstruction performed on the day of the mastectomy versus a delayed breast reconstruction. And delayed breast reconstruction can happen 20 days after mastectomy or 20 years. Now, the longer you wait, the more the breast skin is going to contract. And so the advantage of an immediate breast reconstruction is all of the breast skin, possibly the nipple and areola, are all available to cover the reconstruction, cover an implant, cover a deep flap or a tug flap or a pap flap. And so that's a huge cosmetic or aesthetic advantage for the reconstruction. A delayed reconstruction can still be performed, but many times there's a lack of skin. And so we will either combine a natural tissue reconstruction with an implant or just perform a pure natural tissue reconstruction. And the advantage to the natural tissue reconstruction is we can take the skin with that reconstruction. So for example, skin from the abdomen from a deep flap and replace the breast skin so that there's a pleasant shape. You have adequate projection and a cosmetically appealing breast shape.
Yeah, thank you. I have a number of other questions that I'm going to go through, but just want to remind our audience, both on Zoom and Facebook, to feel free to ask any question. We'll get to them as soon as we can. So another question that we got ahead of the webinar is as follows. I have mentor implants. Recently, it was discovered that one of them ruptured. How soon do I need to have it removed, and what are the pros and cons of replacing it?
So I touched on it a little bit before. You should have it replaced sooner rather than later, because you do want to replace it hopefully while it's an intracapsular contained rupture rather than a extracapsular reconstruction, extracapsular rupture. So it's not an emergency. It doesn't need to happen in the next week or two, but it should happen sooner rather than later. The pros are, the device has ruptured, it's damaged, and it should be replaced. A ruptured device can lead to a capsular contracture with time. And a extracapsular, if your intracapsular rupture becomes extracapsular, it's now a little bit more difficult to remove all of that silicone. It can start to interdigitate in the soft tissue. It can cause inflammation. It can cause some discomfort. And actually free silicone after a while will start to be picked up by the lymphatic system. So if you have a long-term ruptured implant, on imaging, you'll see silicone in the lymph nodes under the arm sometimes. And so it basically takes a fairly simple operation when it's intracapsular and makes it a more extensive, more uncomfortable operation as an extracapsular. So you do want to do it.
Thank you. The following question is one that actually I hear a lot when I talk to a number of people that unfortunately have, have to deal with that issue. And it goes as follows. My doctor does not listen to me. So it starts that way. He did the breast reduction type mastectomy. Now with fat grafting, he says it will not make much difference and I hate the way I look. What are my options? And actually I do, that's also one of the reasons we at Outcomes for Me are very passionate about, empowering people with the information they need to not only have the conversations they should have with their doctors, but also access potentially other alternatives. And I hear this a lot. Recently, we've been doing a number of research on this, where people, depending on the experience they have with some doctors, there's an underappreciation of something you said earlier, which is the quality of life that comes with reconstruction and kind of being able to feel comfortable and good with one's own body.
Yeah, so I definitely agree with you. I think this particular patient situation is either she has a doctor who's not very sympathetic, and that's a reason to seek care elsewhere, or the doctor may be at a loss as to what to do next to fix the situation. And again, having a second opinion is never a bad idea. I actually encourage patients to have second opinions when they see me if they're questioning it. Sometimes hearing two physicians say the same thing is very comforting. And then, your decision on which way to go, sometimes you can't make a wrong decision. You're in good care either way. But if a patient is being told there's, nothing more I can do, I would definitely encourage them to get a second opinion and see what the options are. The purpose of a reconstruction is to make a woman feel, or a man feel, to feel like themselves, to feel whole. And so I think as physicians, we need to be a little bit humble sometimes. And if what you accomplished the first time around is not achieving that goal of, having the patient feel like themselves, then you're not done. And so you have to kind of say, okay, what else can I do to make things better here?
Great. And actually, for those of you that joined us as we were speaking, and I'll go back to this, Dr. Light is offering free consultation actually as part of the partnership we have. We'll be posting that on the web after when we post the video. Linked to actually feeling whole and coming back to a healthy life, we just got this following questions actually on the Zoom. Can I play contact sports like ice hockey and soccer after reconstruction? I am only 48.
Yes, the answer is yes. After you give the appropriate time to heal. The biology of wound healing is that it takes any scar about 6 to 8 weeks to have strength to it. And so it's a critical time during that initial period that, you definitely want to avoid contact sports and really stressing the reconstruction. But down the road, once that mark has gone by, I have no problems with my deep flaps doing any kind of exercise that they want, or implant reconstructions. But, for a deep flap who had tissue taken from the abdomen, they're going to get back to doing crunches. They're going to get back to doing any kind of core exercise. And I encourage it because, especially for people who were fit before, when you're out of the gym for, 6 to 8 weeks and the only approved exercise initially was kind of lighter exercise, you're going to be a little bit out of shape and you're going to want to get back into things. So the best thing to do is just to take it slow, take it incremental. You're not, what I always tell my patients is you're not training for a marathon. So if this week you're doing 5 miles and you want to push it to 7 the next week, this is a little bit different. You're healing, you're recuperating, so you have to listen to your body. And when your body's ready for it, it'll let you know.
And actually, talking about recovery, a question we got earlier is, the pain linked to recovery. So I'm really concerned. The question goes as follows. I'm really concerned on the pain level of recovery. I can't tolerate most pain medication, and the ones that I don't react to don't seem to work. So is there any pain in terms of recovery from a reconstructive surgery?
So there's certainly some pain after any procedure. Pain is definitely subjective. You will have some patients that, do the same procedure, same exact recovery. They'll report pain was a 7 out of 10 the whole time. And then you'll have another patient that was a 2 out of 10. So you do have to adjust your management. The same approach doesn't work for every patient. For patients that are a little bit concerned, I will say that, over the last 5 to 7 years, pain management has certainly improved. We're now using ERIS protocols, which is enhanced recovery after surgery. It was more kind of early adopted in colorectal surgery and some other surgical specialties, but plastic surgery, especially breast reconstruction, has now adopted ERIS protocols. So what they essentially include is during the procedure, doing nerve blocks to help numb the area. And some of those nerve blocks can last up to 72 hours. So really the first critical 2 or 3 days, you're actually covered pain-wise pretty well. We're using a lot of Tylenol, both in the IV form and the oral form. We're using non-steroidal anti-inflammatories, like something as simple as ibuprofen. Ibuprofen, when taken with Tylenol in a standing fashion, meaning whether you have pain or not, 3 or 4 times a day, really does a great job of keeping your pain level low. It may not rescue you from a 7 or 8, but it keeps you at a 3 or 4. And for many patients, that may be enough.
Great. So another question we got goes as follows. After 3 months of placing the implants, is it normal for me to see and feel them move and be swelling on the upper side of the breast?
So feeling the implants move are certainly possible 3 months out. I would say excessive movement may be the implant pocket is a little bit too loose, and so the implant is allowed to shift back and forth. The other thing that we see sometimes with regards to implant movement is if the implant is placed under the chest muscle, the pectoralis muscle, in what's called a submuscular reconstruction, because the implant is under the muscle, when the muscle tightens, it's able to push the implant. And so that's something called implant animation. And for some patients, it can be quite significant. It will only happen when the patient is moving. So if you pose for a picture and you're completely relaxed, you won't see it. But if you go to lift something up and you're using that muscle and it tightens, you will see it. And so the treatment for that is either to take the implant out and put it on top of the muscle in what's called the prepectoral position, which is a fairly common procedure that we're doing now, or you take the implant out completely and you switch to a natural tissue reconstruction.
We just got a question on Facebook. The question is, what is the process for getting nipple? I assume to kind of, for getting the reconstruction of the nipple. Yeah.
So an actual nipple reconstruction is a minor surgical procedure where the skin of the breast is actually elevated and kind of brought upon itself, kind of like skin origami to say, and that actually will create a cylinder of skin. So that's actually the projection of the nipple. The areola can then be reconstructed either with a tattoo or a skin graft, depending on the patient and what their preference is. The other option is to reconstruct the nipple and areola with a 3D tattoo. And we actually have a 3D tattoo artist that works with our practice, Nicole Rizzuto, and she does an absolutely great job. There's a few tattoo artists throughout the country who, have their work online, and they do a great job, and they're really very, very realistic.
Another question, is radiation safe with saline breast implants? Yeah,
so radiation is safe with saline breast implants. Basically, same safety profile, whether it's saline or whether it's silicone. The chances of capsular contracture are roughly the same as well.
We just got a question from Tanya. I had a lumpectomy and was happy with my breast. Several months after radiation, my breast has changed along with extensive scar tissue. What are options to correct this?
Sure. So radiation following a lumpectomy will do a few things to the breast. It will cause the skin to tighten or contract. It can change the skin color. Initially, it's a little bit red. The skin may peel. The skin can then possibly darken or become what's called hyperpigmented. And you can have a little bit of a loss of breast volume as well. So common things that are done to adjust after a lumpectomy, there may be a revision of the scars if there's excess scar tissue there. There may be fat grafting to help fill a lumpectomy kind of contour abnormality or concavity. Sometimes we'll use local flaps like intercostal artery perforator flaps or thoracodorsal artery perforator flaps. They're all small local flaps around the breast, which we can move in to fill the lumpectomy cavity and basically smooth out the breast and restore the shape. Many times we'll also, if the breast size has reduced due to radiation, we can adjust the other breast as well, do a reduction or a lift so that they're matching a little bit better.
We'll be wrapping up in 5-10 minutes. So if you have any questions, just make sure you kind of fill them now so that we can get that to them. So a couple more questions here. One question is so does double mastectomy, prophylactic double mastectomy, so, as a preventative measure followed by reconstruction, the reconstruction result, is it different in that setting from reconstruction after the breast cancer diagnosis?
No, especially not if it's an early breast cancer, which doesn't require any radiation afterwards. So radiation is the one treatment after surgery that can affect the appearance of a breast reconstruction. Chemotherapy doesn't, hormonal therapy doesn't, as we talked about before. So a prophylactic mastectomy can have a very similar appearance or identical appearance to a therapeutic mastectomy.
And I talk to a lot of people that kind of, sometimes are taken aback by the feeling. So in other words, when one thinks about reconstruction, or at least some think about reconstruction, we have this projection that actually kind of, essentially it's getting the same feeling. Can you speak to whether some procedure are better in preserving feeling versus others, elements of beyond the aesthetics, just the feeling of the breast and even the nipple, kind of that entire part.
Sure. So as far as sensation, after the loss of sensation is related to the mastectomy, because the superficial sensory nerves are all cut during the mastectomy. So if a patient undergoes a natural tissue reconstruction, they do have the option to have sensory restoration. So what I was discussing before, where a nerve is identified on the chest wall and a nerve is identified on the flap of tissue during elevation. And once the tissue flap, for example, a deep flap, is brought up to the chest, the two nerves are connected. And sometimes because of the distance and the gap, a nerve graft is used to kind of bridge that. And so that allows sensory nerve fibers to basically reinnervate the breast flap and improve sensation. So that's the one advantage that autologous or natural tissue flaps have as far as sensation. There have been some studies that are starting to look at using these nerve grafts in implant reconstruction as well, to try and reinnervate or connect to the nerves right behind the nipple and areola complex. But it's early on, so it can't really speak to the efficacy as of yet.
And Molly just asked a question here. Can restoration of feeling be restored with lumpectomy?
So the loss of sensation related to lumpectomy is definitely minimal. You still have the breast tissue there. So you may have some localized loss of sensation right in the lumpectomy cavity, but the majority of the breast should still have sensation.
And what if for whatever reason sensation is lost, can you reinforce sensation in that context?
Not surgically.
Okay.
Yeah. So the resensation procedures that I was mentioning are all for mastectomy.
Mastectomy. Yeah. Another question we got from actually somebody, so talking now about stage 4 breast cancer, metastatic breast cancer. So the question is, why won't they do mastectomy on stage 4 patients? I understand there isn't research to prove it extend life, but what about patients' mental health? And since we're talking about reconstruction here, so in the context of reconstruction, or, do you see patients that have advanced stage breast cancer, metastatic breast cancer, having reconstruction, and if and in what context?
So the purpose of mastectomy is to treat the breast cancer and chemotherapy as well, and try and prevent it from leaving the breast. So once the cancer has left the breast, that opportunity is no longer there. And so the treatment really the mainstay of treatment becomes chemotherapy, hormonal therapy. And so there are really rare instances where a mastectomy is done for metastatic cancer. Now, not all metastatic cancers are the same. A single bone lesion may be different than multiple metastases and in multiple organ systems. And so there are some exceptions that are made, but all in all, that's the primary reason why mastectomy is not. And I get where the question is coming from, the concern of having the cancer there, but I think you just have to kind of take it in context of why the treatments are done and what the benefit are. And if there's really no benefit and only surgical complication as the upside, then the best thing to do is to try and reduce and downstage the cancer to possibly get to a position where surgery is an option. And the best way to do that is with chemotherapy and hormonal therapy.
And I do want to, before we close, take one more question, which is around long-term outcomes. So the question is there any data regarding long-term outcomes being affected by having reconstruction surgery or not? And so I assume that question was more on the breast, long-term outcomes in terms of breast cancer. But I also want to ask the question, which is probably a second question, which is, what do you recommend for people that have had reconstruction surgery in terms of follow-up or monitoring and, in the context of just screening for the longer term?
So I'll answer the first part first. There's no data to suggest that having a breast reconstruction will increase the chances of, for example, recurrence. And actually, a common question is, if I move my tissue, for example, my abdominal tissue, a deep flap up to the chest, can the deep flap get breast cancer? Can I have a recurrence in the deep flap? And the answer to that is no. There's no, the breast cancer is originating in the breast gland, the breast cells, not in fatty tissue. And the deep flap is essentially a deep flap, a tug flap. Any of these autologous flaps are skin, fat, and possibly muscle. And so you will not have a recurrence in the deep flap, and it will not increase the chances of having a recurrence.
And how about just monitoring, right? So in other words, if you do a double mastectomy followed by reconstruction, my understanding is just, you no longer do mammograms, right? So what is any screening that or what are the guidelines today for screening, and how often?
So this really falls under the kind of the umbrella or the hat of the breast surgeon. And so it's definitely critical to continue to see your breast surgeon or your medical oncologist, whoever's going to do the long-term follow-up. And each practice, each physician may have a little bit of a different approach to this. Commonly, it's physical exam. You're right, there are no mammograms. If there's concern, there may be an ultrasound or an MRI. But there's definitely, initially patients are usually seen 2 to 4 times a year. And then, as time goes on and they continue to do well, that may be reduced to once a year. But all breast cancer patients really should be having, a follow-up, at least one follow-up exam a year with their either breast surgeon, their surgical oncologist, or their medical oncologist.
And from a reconstruction standpoint, how about implants, right? Like we've talked earlier about rupturing of implants. Do you need to monitor it? Is there a frequency that, a reconstructive surgeon would recommend in terms of, monitoring the implants?
So there are recommendations by both the FDA and the implant manufacturers. And this is for silicone implants. A silicone implant and a saline implant are basically, they both have a silicone shell. The difference is what's inside the implant. A saline implant is salt water or saline, and the silicone implant today is filled with a cohesive silicone gel. So because the gel in a silicone implant is cohesive, meaning it sticks to itself. So there are actually photos of implants that are cut in half, and the silicone inside doesn't go anywhere. It's almost like a jello. And so silicone implants, if it ruptures or cracks, you won't know that it happened. If a saline implant ruptures, your body will start to reabsorb some of that fluid. The size of the breast will go down, and you'll know that something has happened that I need to have it evaluated. With the silicone implant, because you really can't pick it up just on physical exam, the FDA and the implant manufacturers are recommending that a MRI is done 3 years after the implant is placed, and then every 2 years after that.
Great, thank you. So I know we're coming to the end of our time, so I just want to take this opportunity to just close our session. Thank you, Dr. Light, for taking the time today. And just for everybody who has attended, if you have any follow-up questions or thoughts, please email us at questions@outcomes4me.com. We will be sending out, follow-up survey for your feedback on what you would like to see in the future in terms of webinars to cover. And we'll also make these videos available in our app, along with a blog recap if you want to revisit or share with others. And also, I just want to remind everybody, that Dr. Light is offering free consultation for members who have downloaded our app. To schedule a consultation, we'll be sending information. Log into the app tomorrow and find the link under the recap webinar on our homepage. And finally, to make sure that you don't miss any future updates or other partnerships such as this one, please make sure that not only you enable the push notification on the app. And thanks, and stay safe, everyone. And again, thank you, Dr. Light, for being with us today.
My pleasure. Thank you for having me.
Thank you. Thank you, everyone.